Hi everyone, welcome to another Monty Hart lecture series. We have the great honor to have today Dr. Allan Jaffe, who will be speaking about making high sensitivity cardiac troponin your friend for the diagnosis of ACS. Dr. Jaffe is a world-renowned scientist and expert in the field. He's a professor of medicine in the Department of Cardiovascular Medicine and professor of laboratory medicine and pathology and the Wayne and Catherine Praisel Professorship for Cardiovascular Disease Research at Mayo Clinic. He completed his residency and fellowship training at the Washington University School of Medicine in St. Louis, where he rose to professor of medicine. In 1995, he became chief of cardiology and associate chair of medicine for academic affairs at the State University of New York at Syracuse, and then he was recruited to the Mayo Clinic to work clinically in the area of acute ischemic heart disease and to continue his work on cardiovascular biomarkers in laboratory medicine. He has been awarded the Distinguished Teacher Award by the American College of Cardiology and a Career Achievement Award for his targeted contributions to the laboratory community by the American Association for Clinical Chemistry. He was recently honored by the International Federation for Clinical Chemistry for his contributions as well, and he has been a principal for all of the 4 iterations of the universal definitions of MI. It's a real honor to have you here today. We're very excited about your lecture. Thank you so much for sharing this lunchtime with us.
My pleasure to join you. It's a little before lunch here, but if anybody is having lunch, please enjoy. Please note that I have in the past or presently consult for most of the major diagnostic companies. When I say nice things about them, they love me. When I say things they don't think are as nice about them, they all hate me. But you can take that into account in any way you wish. Let's start out by talking a little bit about some of the analytics of assays, not to make you experts, but to give you some background. The first thing to say is that all assays are different. This is a tabulation done by a friend and colleague, Fred Apple at Hennepin County Hospital, where he collected putative normal subjects and sent them all to the companies to have the companies measure the values with their high sensitivity assays. These are all putatively high sensitivity assays. What you will note is that the 99th percentiles, which are shown in these orange bars, are different for every assay. And the percent measured, which in order to be a high sensitivity assay should be 50% of women and 50% of men, is not always achieved by these assays that call themselves high sensitivity. So the buyer needs to beware about this, and you need to look at the peer-reviewed literature, and the International Federation of Clinical Chemistry has a nice website that tabulates all of this for those of you who are interested. The 99th percentiles not only are different between assays, but like it or not, males have higher cardiac troponin values than do females. Some, depending upon which assay you use and how much difference there is between the male and female cutoffs, can subsume a large number of patients. There's been some controversy with some assays, in particular with whether troponin T, where the difference is not so great, where it makes a huge difference for the diagnosis of MI. I think that's in part because those studies that come from Europe only include chest pain patients and therefore don't include the atypical presentations that so often accompany female sex. So I'm a big advocate for the use of sex-specific cutoffs, and the reason for it is shown here. These are data that come from Edinburgh, from the high stakes group, utilizing the assay that you're moving to, which is the Abbott assay. And this was a prototype assay, so the numbers may look a little different. But note that the yellow line is below, patients who are below the 99th percentile for women. They do very well. Here is the concentration if you just take all comers who have a value above the overall concentration. In the middle, the women, since their upper limit of normal is 16, are there. And if you look, those individuals have an equally bad prognosis. So the intent is not to increase the numbers so that they look like these are equivalent populations, as in some way that's a good thing. But this identifies individuals who are at high risk when you use sex-specific cutoffs. This is the data that we use to set our normal cutoffs at Mayo. It comes from a paper that I helped write in clinical chemistry in 2010 for the high sensitivity troponin assay. You can see the differences are 10 and 15. Now, in addition to some information about the differences in assays, you should be aware that all assays, every blood test, has things that will cause it to increase false positively or decrease. This is a tabulation of some of these. The most common are what are called flyers. A little piece of fibrin gets stuck in the analyzer, gives you a high value. If indeed you have a high value and it doesn't fit your patient, asking the lab to recentrifuge and redo that sample is a very, very wise thing to do. There are also a variety of antibodies that exist, and we could spend a lot of time talking about each one of them. Some of them reduce values, some of them can cause false positive values, like heterophilic antibodies, which are antibodies that either cross-react or are antibodies to the immunoglobulins that are made. For troponin T, there is a signal that can come from skeletal muscle that so that patients with chronic skeletal muscle disease can have elevations in troponin T, not I as far as we know. Hemolysis is a big problem. It lowers the values for troponin T, but it increases the values for a lot of your eye assays. So if you look at how we get hemolyzed samples, if I put on my lab hat, it's from draws through lines. So if you want to improve the quality of the samples you send to the lab, and with it, the quality of the results that you get, trying hard to avoid line draws would be helpful. When we introduced high sensitivity troponin at our institution 5 years ago, we banned line draws in the emergency room because it used to be that they put in the IV and then drew the sample, and that was helpful. There is an issue that is now gone called having to do with biotin, but probably for some of you it may be important to understand many of these assays use streptavidin and biotin, and that's never been a problem in the past until women discovered that taking additional doses of biotin improve your skin, your hair, and your nails. If it worked for women, it got put into all of those supplements that you see on TV that all say, you know, are you losing your strength now that you're a middle-aged man? So there's a lot of now high doses of biotin, and that can lower troponin T values, and by the way, other values for a variety of other analytes. The one that is more common today, and I'm not going to take you through this cartoon, is something called macrotroponin, and this is an important one. Macrotroponin is a conglomerate of troponin and immunoglobulins. And what it does is, because they bind together, this big complex stays in the circulation for a long period of time and can cause high values. It's very rare with troponin T. It's much more common with troponin I assays. And just to give you some examples of how you can be fooled if you're not careful. This has been reported in patients with possible ICI myocarditis. Someone comes in, you're worried about them, you get a troponin, it's elevated, you assume that it represents ICI myocarditis if they're an immune checkpoint inhibitor. It has been seen after COVID vaccination. After COVID vaccination, if you have some sort of symptom and you go to the emergency room and your troponin happens to be elevated, you assume this is myocarditis. In point of fact, it may be simply a macrotroponin. Now, it's even possible that because we have been vaccinating people so aggressively in the past 4 or 5 years, that some of this is something that we've caused ourselves. It's hard to know because none of us have the data sets to look pre and post COVID pandemic to see if this has changed, but it is worth knowing about. And the bottom line here is if you don't like, and it doesn't fit the troponin value, whether it's low or high, it doesn't fit your patient, asking your lab to do some intelligent troubleshooting is important to do. Some of this is very simple, some of it's more complex, but making those requests is the only way the lab can do this for you. Some basic principles. One of the questions I get the most is, oh my gosh, we're going to high sensitivity assay, we're going to be swamped with elevated troponins that we're going to have to explain. Well, partially that's true, partially it's not true. It depends almost as much on the assay you were using previously as it does on the assays that you're going to. If you use a very insensitive assay as the 4th generation troponin T was, even if you used it at the right cutoff of the 99th percentile, you saw this big increase. On the other hand, for the assay I'm told you're going to be using, the values are more harmonized, and if you were using the 99th percentile previously, and you continue to use the 99th percentile, you won't see a big increase. Now, this is an important concept because, like it or not, and I don't like it much, a large percentage of hospital systems don't use the 99th percentile. These are data that we collected as part of the ischemia trial of the sites. What you can see is that less than 50% of individuals use the 99th percentile laboratories. Most use something higher. Why? Because clinicians were saying, we've seen too many elevations. We want you to use a higher value, and labs have the right to do that if they think that's what's right for their populations. So if indeed you were using an inappropriately high value for your 99th percentile, you will see a big increase. If you weren't, the likelihood with the Abbott assay that you'll see much of an increase pretty small. Evaluating these values is pretty simple. If you have an elevated troponin, by definition, you have myocardial injury. If the values are unchanging, and the universal definition suggests that less than a 20% change, you should call this stable. You have chronic myocardial injury, structural heart disease, IHSS, hypertrophy, chronic kidney disease. You have an elevated troponin, and it goes up as a rise or fall. You have acute myocardial injury. If it's with ischemia, you have acute myocardial infarction, and you can look and then figure out what type of infarction you have. If it's without ischemia, you have myocardial injury, acute heart failure, myocarditis, and the like. So one of the important principles that will help you tremendously is to make your own pretest probability before you get the troponins. I don't agree with these numbers, so ignore the numbers, but the principle is the same. If ischemia is unlikely, even if you have an elevated troponin, the likelihood of acute myocardial infarction is small. Now, the value is higher. The higher the value, the larger the percentage, but still the vast percentage is not myocardial infarction. On the other hand, if you've got a clear-cut ischemic presentation, either by ECG or clinically or by echo or by angiogram, a elevated troponin is enough for you to make a diagnosis, even though eventually you'll want to see that rise and fall. If you don't make a pretest probability and the troponin comes back high, then the troponin ends up driving the car rather than the clinician driving the car. If you want to use this and keep yourself out of trouble, make a pretest assessment and then go with it and use it, the troponin, to modify that subsequently. Otherwise, you can end up tracing the troponin, which is often unsuccessful. The majority of new increases, if you see any at all, are probably not going to be in ACS patients very much. There's a small number of individuals who will go from having unstable angina to having non-STEMI. And we'll talk a little bit about unstable angina right at the end. The majority of other cases will be in a non-ischemic heart disease area. So heart failure, arrhythmia is common, or acute critical illness. The importance of recognizing this is no matter which bin you fit in, an elevated troponin is a high risk factor for adverse subsequent events. And it's not rocket science. If you're sick as stink and your heart is involved, you're worse off than if you're sick as stink and your heart isn't involved. It's literally that simple. So in every one of these, there's good data to suggest that you should take the troponin seriously. That doesn't mean taking them to the cath lab. All right, often this is non-ischemic myocardial injury. Now, the approach we took at the Mayo Clinic, and in teaching about this, it provides a good template for teaching. I'm going to use the ESC 1 hour algorithm and criticize it as we go along. Okay. And there are multiple components to it, so let's go through them. The first component is that there is the so-called single sample rule out. What that is to say is that if your value is sufficiently low, with some caveats that I'll share with you in a moment, that the likelihood that eventually you will have a rising and falling pattern with values above the 99th percentile can be estimated and is quite small. So the single sample rule out, this is a meta-analysis many of us participated in. If you do that, this is with troponin T, the very low number, which was less than 5 in this study, with a non-ischemic ECG, these patients had a almost 99% sensitivity for excluding myocardial infarction. Now, there's a caveat to this, and these patients are all at least 3 hours from the onset of symptoms. The best data in regard to that is shown here from Nick Mills. They actually showed that at 2 hours, patients who come in at 2 hours or less from the onset of symptoms are less well triaged with it. So if you're 2 hours, some would say 3 hours from the onset of symptoms, and you have a very low value, and there's been a randomized controlled trial of this approach using the assay you're using, the Abbott assay, and the value that seems to be key is 5, then you can be fairly comfortable that you have a highly likely rule out. And that's an important, it can be as much as 20 or 30% of your population. Not only does it say you're not having an ischemic event, one of the reasons it works is shown here. All of the risk factors for atherosclerotic cardiovascular disease cause graded increases in troponin, albeit within the normal range. So it says not only is it less likely that you have an acute event, but it's also unlikely that you have the underlying substrate, i.e. ASCVD. Now, in the United States, we did a study, and there's important information here because in the United States, the FDA restricts which values you can report. Not a problem for your assay. It was for our assay, where they don't let us report down low enough. So we did a study where we looked for the presence of myocardial injury in our population, and it worked perfectly in men. But it didn't work nearly as well in women. And that's an important concept. Here's an example. This is a woman who had a stent in the past. She came in, she was having more substernal chest pain. She presented twice and was sent home because the values were so low. They called me up and they said, gee, do you think we should do something? I said, sure, you should do something. No test is perfect. Here's her ECG. Her troponins were normal again and low. But here's her angiogram. And she had a distal PDA lesion. We've seen ones with even more proximal lesions as well. So it's not common. But what it says is this is not something that this approach of a single sample rule out is not something you put on autopilot and stop thinking. It's something where you need to be careful. And the group to be careful about are women, older individuals who present atypically, and you're not as suspicious as you ought to be. In this study from Israel, looking at the single sample approach, and in patients who have known coronary artery disease. So don't put this on automatic pilot. Be cynical. And if worse comes to worse, maybe you need to get another sample at 1 or 2 hours, depending upon what protocol you elect to endorse. The second part of the ESC algorithm says you look at the change in a sample between 1 and 2 hours. And for troponin T, which is the assay we use, it's the difference between 3 and 5. Now, I'm not going to try and make you laboratorians. I'll put on my lab hat, tell you that this precision profile for the troponin T assay cannot allow you, if the values are within the normal range when you start, to make any distinctions between 3 and 5, not until they get substantially higher that the precision profile will allow you to do that. But I'll give you a better example having to do with your own assay, the Abbott assay, where Pete Kavsak and I put out 50 random samples. We just let them sit on a bench for 3.5 hours, 3.5 hours, and repeated them 3 times. A third of patients changed categories. So we said, hey, 1 hour is not enough. The distance needs to be more. Now, the contrary argument, just to be fair to others who disagree, is that there aren't too many people who fall in this bin, but we didn't even want the idea that we were going to endorse an approach where we knew we were going to misclassify some patients. So what we did was we went to a 2-hour protocol. Now, one of the arguments in this area is that the people who are advocates for the 1-hour protocol say, hey, you're right. We understand the analytics, but clinically, we haven't seen this, and I disagree. This is from a study called RAPID, where it's a complicated study we could discuss if you wish during the question and answer period, but they had a masked 1-hour protocol, and they had a 13% representation rate, people who came back. And over time, they had increased mortality. So I think there are data that say we missed some people. It's hard to know exactly how many. So this is what we use. This came from the PACE group. We use a cutoff of 0.4 to rule in. You can see it's not perfect. And less than 4 to rule out, more than 10 to rule in. less than 4 to rule out, to give ourselves greater guidance. And I'll show you our results a little bit later. An additional component of the rapid algorithms is this idea that if you have a magic high number, you can make a diagnosis right away. That probably works reasonably well if you only include typical chest pain patients who you are only concerned about ischemic heart disease. And in point of fact, if you look here, you can see that it's about, from this study, 60%. When you get higher, it ends up giving you higher values. But this study is one of the European studies that only use chest pain patients. In the United States, REDs monitor and collect and draw and measure troponins in a far more heterogeneous population. These are our data now published in Mayo Clinic Proceedings. If you take all comers with chest pain, you don't have a very good positive predictive value for MI at all, even out to 100, which was the line in the sand that we put in when we were just starting and have now modified. But if you take the chest pain patients, you do better. So for a classic patient, a very high value is important. For the average patient, and there are more than half of these individuals in this particular analysis were not MIs, it doesn't work so well. So this is what we do. We use the single sample rule out of less than 6, a delta of 0 and 2, a delta greater than 10 we rule in, and then this group, which I'll show you in a minute, is about 15% of our group, needs a third sample to see whether or not they continue to rise. Here are our data. This was looking at the transition at a couple of our community hospitals in the Mayo Clinic Health System. You can see the frequency of MI went from about 3% to 8% with high sensitivity, predominantly because there was a big change in the frequency of type 2 MIs. Also notice that for troponin T, and this is more unique for troponin T than I, there was a large percentage of patients with increases due to myocardial injury. And for whatever the reason, troponin T is more apt to give one elevations due to non-ischemic myocardial injury than the I assays. We spent 9 months getting our system ready for this change with lots of education. This included having advocates and champions in each of the areas. So as opposed to a cardiologist coming down to the ED and saying, here's what the ED ought to do, you find an ED physician who has interest in this and has expertise to train his brethren. Same thing with the lab, same thing with cardiologists, same thing with hospitalists. If you don't do this, then you might end up with different results. But we ended up with a tiny increase in the amount of coronary angiography. And that's about it in terms of resource utilization. Some lessons learned. I was up in clinic when I first saw this. Became clear to me that I hadn't educated about this point adequately to my ED brethren. So I went down to the ED and spent a week. This is the first day I was down there. Was a 46-year-old man who came in, had a 3-week history of a cold feeling in his sinuses, like he drunk something that was too cold. But it went to his chest very, very rapidly. And it would last 5 to 10 minutes. And often it was exertional, but he had some rest pain. He had some shortness of breath. Thought that was due to his asthma. He'd been stressed recently. He didn't have a family history because he was adopted. His blood pressure was sort of marginal in ED. He didn't know what his cholesterol was. The reason to be suspicious about people like this, and I'm going to go fine. I'll come back to this. Here's his ECGs, but his values were elevated. And there was no other cause for this that I could see. So what did I do? I said, gee, if you took away the funny cold feeling in his nose, it's a classic story. Mostly exertional, chest discomfort, happens at rest as well, usually exertional, some shortness of breath with it. So I sent him to the cath lab. Now, why does this occur? And these slides are out of order, so I'm going to go back and just to make sure you see this. Come on. These are data from a fellow named Jorman from Sweden. And he basically described the fact that there were about 25% of the patients that they saw with non-STEMI didn't have a changing pattern of values. They didn't have acute myocardial injury. And the reason for that was that they were on the downslope of the time concentration curve. This is an illustration Mayo was kind enough to make for me to put in the universal definition. The upslope's fast. Seeing a change over 1 or 2 hours, pretty easy. But once you reach the peak, you could have 2 values up here, and the downslope's a lot slower. What time periods are these? Well, troponin release relates to blood flow. So this is maybe 8 to 12 hours to peak if you have an open artery. Maybe it's 18 to 24 if you have a closed artery. So it can vary quite a bit. So what I teach is, if you see somebody who has an increased troponin and you can't explain it, at least go back and wonder whether or not there's underlying acute ischemic heart disease before you give up. Another lesson. It's a 68-year-old person with hypertension, hyperlipidemia, positive family history, had a calcium scan in the past. It's a walker and had substernal chest pain radiating to his scapula during a walk. The day of admission, he had a 2-hour episode, came right to the ED. So he was perfect. It's an ECG. His troponins weren't elevated. They were on the upper margin, but they weren't elevated. So I had a very good colleague, smart guy, called me up and he said, Allan, I love your test, but this doesn't look like it's working for me. I said, look, if you're suspicious, it's unstable angina isn't totally gone, be careful and do something else. So he did. He did a stress test. And here's the stress test with this gentleman's typical pain and ST elevation in the inferior leads. Whoa. Wait a minute. Somehow we missed something. Huh. Well, it doesn't want to show you the angiogram of the high grade right. Finally, another patient, 78-year-old with hypertension, chest pain, had more chest pain of late, a day's worth of tightness before coming to the ED. She'd had a stress test about a year before, had seen one of my colleagues. And so the ED said, well, this probably isn't ischemic heart disease, so they ruled out PE. And when that wasn't forthcoming, they admitted her to my ischemic heart disease service. Here's her ECG, not very impressive. Those of you who are aficionados may see some suggestive abnormalities, but her troponins first 2 were normal, and I was getting ready to see her and had the house staff get another one. which turned out to be elevated, but I was worried she was on the downslope, actually. When they called me, and again, I'm sorry, I'm sorry you can't, it's not playing the echo. But one of my colleagues called me to say, Allan, there's a regional wall motion abnormality there. She had a normal coronary angiogram. So I sent her for an MRI, and here's the perfusion defect in the septum. So what is this? This is MINOCA. This is myocardial infarction with non-obstructed coronary arteries. It's about 6 to 10%, depending upon what study you use. Here is a tabulation of our data that we published some years ago of patients who admitted because they had a good story, an elevated troponin, and had an angiogram. And the angiogram was normal. So because there was still suspicion, and are more studies like this in the literature, they underwent MRI imaging. What you can see is that about 20% had infarctions, small, but the biggest mimicker was myocarditis, non-ischemic chest cardiomyopathy, 20%, stress cardiomyopathy, only 17% were normal. And in point of fact, if one looks at the composite literature over all of these studies, what you'll find is that the earlier you do the MRI, the better your yield, and you can get answers in roughly 90% of people. Now, I'm not here to tell everybody time you have an elevated troponin, you can't explain this, you should get MRI. I'm not trying to break the bank. But if you think you have a good story that fits, and in particularly if you then have an angiogram that is normal, going after it is a good idea. A stress cardiomyopathy is not a good thing to have. Myocarditis isn't a good thing to have. Even small infarctions aren't. And if you look, this gets complicated. This comes from your city. This is a montage that was done and published by Harmony Reynolds, utilizing sophisticated IVUS and OCT. And about half of the 42 patients she studied actually had plaque rupture events. They were type 1 events just below the resolution of the angiogram. Another subset of these have microvascular disease. Some of these individuals can have SCAD. It's complicated. Oops. These patients are not totally benign. They're at risk. They're not as much at risk as if you have epicardial coronary artery disease, but they are at risk compared to a normal control population with increased events depending upon who it is, their age, and a variety of other comorbidities. So don't miss MINOCA, and you'll start to see more of it with high sensitivity than with the others. I'm going to end now. Hopefully, the most important message that you can get is here. It's not the data, but how you interpret it that is important. And with that, I will close and leave plenty of time for questions.
Thank you very much. That was a very wonderful lecture. I think I learned a lot. And congratulations again for the amazing career and all the work you've done in the area. If you want to exit the presentation mode or just stop sharing maybe, so we can then go for questions. For everyone, you can stop sharing the screen if you want, probably.
Yeah,
so if you have questions, please put them in the Q&A and we'll go through them. I will start with a question that I've asked you before, that is about the role of CPK and in clinical practice and in clinical trials. I mean, some trials still request CPK for enrollment. but clinically the value may be different. So what is your approach to CPK testing?
Most of us don't use CPK at all. At least CPK-MB.
Yeah.
Several things about this to say. First of all, hopefully I've stopped sharing. First of all, troponin is much more sensitive, much less prone to false positives because CK is a fairly dirty analyte. It comes from skeletal muscle. It comes in patients with renal failure. And almost anything you can do with CKMB, you can do better with troponin. The two areas where there was some controversy, there were actually three. One was if you didn't know where on the time concentration curve you were on, because CKMB comes down. But they're now good data that when you have a reinfarction, you go back up with troponin and you see it easily as long as you're on the downslope of the time concentration curve. A second argument about this had to do with the cath lab and post PCI injury. And this is a canard. Basically, you can anticipate, and we've published good data about this, but the interventional cardiologists don't want to hear it. If your troponin is elevated before the procedure, the likelihood that it's going to go back up after the procedure is pretty high, much higher than if it's normal. With CKMB, which is much less sensitive and identifies many fewer patients, you then see some who start out and normal and then they go up. It's not even clear necessarily that that is due to the procedure itself or just the natural rise of CKMB, which takes a lot longer to get there. And this has led people, because people want to say, oh, we didn't cause a problem. It's a controversial area because the criteria for doing it aren't well set out. We have in the universal definition, the last iteration, and fifth iteration is being developed, suggested that because PCI can cause some modest elevations of troponin, even under the best of circumstances, that maybe one should use a threefold increase. It still makes the interventional cardiologist angry because there's a fivefold increase with cabbage, and they say that puts them at a disadvantage. But in truth, there's obligatory cardiac injury in cabbage that is much greater, and the studies are really very clear. For both circumstances, the bottom line is the higher the troponin, the worse the prognosis over time. But that said, that shouldn't influence the definition. Because if you have a really high troponin, maybe the patient dies. But these modest troponins also play out over a longer period of time as having prognostic significance as well.
Thank you very much.
Total CK is still valuable for the occasional patient with rhabdomyolysis, stuff like that.
Thank you very much. We have a question from Daniel Lorenzati. He says, great practical lecture. In the literature, or have you found or have you looked at any differences in high sensitivity troponin kinetics between type 1 and type 2 MI?
Yes, there's a very extensive literature about that. And type 2 MI elaborates less troponin overall if you look at the area under the curve. But there's so much overlap between type 1 and type 2 that you can't use the troponin values and or the kinetics to distinguish one from the other, unfortunately. Many of us are involved in trying to develop sophisticated AI approaches to this particular problem.
Thank you very much. A question that also came before is on the equivocal cases. Those cases are not ruling in, but are not fully ruling out. Do you use CCTA in these cases, or do you have a protocol for stress tests? How do you deal with them?
Well, they're sort of an accumulation of groups there that potentially there. First of all, about 80 to 85% of the patients after 2 hours fall into either the rule out bin or the rule in bin. There is an observed group, and usually the late troponin, which we get at 6 hours, and the reason we get it at 6 hours, 4 would probably work, but I have to tell you there are no data at 4, and there are data at 6. So we decided we wanted to be data driven, and therefore made for the delay, usually clarifies the circumstance. I think that the better use of CTA is not so much when you have an equivocal case, but when you have an increase in troponin that you can't explain. Like my young guy, and you say, shouldn't have that. Could he have? That's where I think the sweet spot for CTA is. And one of the things that has happened in some institutions, to some extent here as well, is that the ED gets a CTA and there is egregious bad looking coronary artery disease, whether the troponin is elevated or not. And that automatically gets translated into this patient needs to be admitted, needs an intervention. Well, a lot of us, probably as we age, are going to have some coronary artery disease. And detecting it with a CTA is a good thing long term, but I would argue better used in the outpatient setting. But putting all those people into the hospital, we have good data if you have an acute coronary syndrome, but we don't have any data just finding coronary disease. So I often look at those and I consult down in the ED where we have an ED consult service. If they've got normal TIMI flow and they've got no regional wall motion abnormalities, even if they have bad coronary disease, then I set them up. I'm willing to send them home as not having an acute ischemic presentation, but I then set them up for subsequent evaluation. Otherwise, you can get seduced. And there are all kinds of artifacts, and radiologists have a tendency to overcall rather than undercall. So you can fill up your hospital if you're not very careful. So thoughtfulness, and I think that's what I do, can be really helpful. And I think CTA is really important, but I use it more in the outpatient setting. When I see those people come back, then getting a CTA, I think, is better than getting a stress test.
Thank you very much. Yeah, just like you said with MRI, if we use any test for all in any of these scenarios, we'll just overload the modality and it becomes impossible. I think that was a very good point also on the late troponin at 6 hours. That is something that we should look into. So thank you very much. So I learned a lot. I think there's no more questions. I really enjoyed this lecture, and hopefully we'll see you at ACC or one of the conferences to meet you in person.
My pleasure. Glad to. Please, if anybody has questions, feel free to contact me and I'll try and help.
Thank you very much. Take care.
Be good.